All right, let's go ahead and begin. Good morning, everyone, and thank you for being here for my Grand Rounds presentation. Thanks for everybody that's here, and thank you for everybody that is watching online as well. Thank you, Dr. Baker-Watson, for facilitating this. The title of this presentation is A Practical Approach to Patients with Implantable Medical Devices. I personally have always found medical devices such as pacemakers and ICDs to be interesting. And I don't think I'm alone in the feeling that it can be intimidating when these patients present to our care, especially prior to surgery. So hopefully this talk provides some key points which will help you feel more confident about management of these patients. And of course, a special recognition for Dr. Chris Schilf, who really helped me with this and for his contributions to this presentation. So let's begin by discussing medical devices. By definition, they can be described as devices inserted into the human body for means of improving life or physiologic function. Implantable medical devices have been on the rise due to developments in science and engineering, especially in microelectronics and biotechnology, which have made them more versatile and more common. So interestingly, about 8 to 10% of the population in America and about 5 to 6% of industrialized countries have experienced an implantable medical device for achieving a better quality of life or for expanding longevity. So there's a good chance that we all know someone or possibly even related to someone with a medical device. And in our field as anesthesiologists, it is important to know how to manage these patients when they present to our care. So there are hundreds of medical devices available in today's market. This short outline attempts to categorize and describe some of the common devices that may be encountered in the perioperative setting. Some of these devices you may be familiar with, but perhaps a few are less known to you. And my goal is to give a brief description of each device and establish a practical approach for management, more or less divided in a pre, intra, and post-operative fashion that will help you should you encounter these devices in the future. So since most anesthesiologists are already familiar with cardiac devices, let's go ahead and begin this talk by discussing non-cardiac devices. So let's begin with spinal cord stimulators, vagal nerve stimulators, intrathecal pumps, and hypoglossal nerve stimulators, also known as Inspire. Let's start off with the day of surgery here. So we have a 68-year-old male, history of hypertension, hyperlipidemia, obesity, BMI of 55, and OSA, which is not on CPAP, who presents for a right total knee replacement. Further review, labs and heart function tests within normal limits. The patient has cardiac clearance. When you go see the patient upon further interview, you notice that the patient says that they do not use a CPAP, but they do use a special breathing device that contains a remote with abilities to turn the device on during sleep. So what are your thoughts during this interview? What is the next step that you'll take? So likely this patient is presenting with a hypoglossal nerve stimulator, which you can see in this image. In this diagram, you see the nerve stimulator implanted under the patient's chest with a remote that comes with the device as well. These devices are indicated as alternative treatment for obstructive sleep apnea. It's also known as Inspire, as the company is, that's the name. As of 2021, there are more than 17,000 of these devices available. So even today, you're likely to see a lot more. This device works through detection of normal breathing via a sensing lead implanted between the external and internal intercostal muscles. A signal is then transmitted into the stimulation lead, which is implanted submentally and stimulates the branches of the hypoglossal nerve responsible for tongue protrusion, predominantly those to the genioglossus muscle. The genioglossus muscle is the primary tongue protruser and the dilator of the upper airway. So once programmed, the patient can use a sleep remote to turn the device on prior to falling asleep. The device then remains functioning overnight in efforts to protrude the jaw and the tongue in order to minimize symptoms of obstructive sleep apnea throughout the night. Once awake, the patient then turns the device off and resumes with their normal function. So for a preoperative assessment, if this patient presents to surgery, first identification of the device is important. Good questioning, because some patients may not think to mention this device, or they may not think it's important to mention prior to surgery. Next, consideration to other comorbidities associated with sleep apnea is important. So your normal thorough airway exam and plans for a difficult mask or difficult airway placement is important. Keep in mind these patients have obstructive sleep apnea. As far as further device management, specifically pertaining to the anesthesia team, I found very limited perioperative recommendations using fairly in-depth literature review. Therefore, I took the effort to personally contact this company named Inspire, the primary manufacturer of the stim, I inquired about more specific perioperative management. The company recommends that the device should be turned off prior to a planned procedure. And if the patient brought the remote, you can confirm with the remote that the device is off, or if they didn't, you can contact the device support if device status is unknown. Intraoperatively, they recommend the device should not be used as it is intended for personal physiologic sleep, so it's not to be used during surgery. However, if used during surgery, unipolar electrocautery should be avoided, as heat energy can be transmitted through the lead body and may cause nerve damage. But if electrocautery should be used, bipolar is preferred, and grounding pads should be placed as such that the current path is transmitted away from the device. And it's recommended that at least a 6-inch or 15-centimeter separation be between the device implant site and the area of the surgical procedure. If performing MRI, recommendations were interesting in that prior models are not MRI safe, but newer ones are. So for these reasons, it's important to really contact the manufacturer to find out exactly what device the patient has prior to going to the scan. So as anesthesiologists, oftentimes one of our main goals during surgery is to identify and treat obstructive breathing. So an interesting point to consider is there a possibility to use Inspire to alleviate obstructive breathing during surgery? So the company claims about this is that the use of Inspire for airway management is outside of our indication for sleep apnea, is off-label, so they cannot offer any guidance. And Inspire therapy is not intended for life-sustaining airway treatment. Therefore, if ventilation support is needed for the patient during recovery, you have to utilize gold standard equipment such as CPAP, BiPAP, etc. However, I was able to find a case report in which the authors described using Inspire during sedation cases. They write that if the anesthetic is planned as deep sedation or MAC, their choice is to activate the device at the commencement of sedation and to deactivate it once the patient has again regained consciousness. Further, if a general anesthetic is planned, they suggest not activating the device during airway management, but reactivating against once removal of the airway has occurred and the patient is able to breathe spontaneously. In other words, as long as the patient is breathing spontaneously, this group favored this device usage under certain conditions to assist with obstructive breathing, which I think is an interesting point. All right, so let's now transition into spinal cord stimulators. So the majority of spinal cord stimulators are typically inserted for treatment of chronic neuropathic back pain, leg pain, or even both, but they can also be placed in the cervical region or even peripherally for pain as well. Thank you to Dr. Buck for this useful information. So this device has single or multiple leads containing electrodes that are placed in the dorsal epidural space. And the location, of course, the level depends on the region that is causing the pain. The leads are then anchored to the supraspinous ligament and then tunneled subcutaneously and implanted to the pulse generator, which provides power to the spinal cord leads. The stimulator then provides electrical stimulation to the dorsal column, the lateral funiculus, and the dorsal roots. And this electrical stimulation depolarizes and inhibits ascending nociceptive pathways and also increases supraspinal descending antinociceptive pathways, which all together assist with pain management. Patients are often very proficient at using their device, and they can program and change their devices independently. They also know how to switch their devices on and off, typically. On the image here on the left side, you see a schematic of the implant. So you can see the pulse generator by the patient's hip, and then you see the leads going to the electrodes in the spinal cord. And on the right side image, you see typical implant locations. So these are places to look for if you suspect a patient has a spinal cord stimulator. For surgery, the pain team should hopefully be contacted if possible early to provide advice and assistance, as they have access to essential information regarding the device and its management. And this device should be turned off and to the lowest setting before the procedure. I think part of this double procedure here is that if for whatever reason the device were to be activated during surgery, the lowest possible stimulation would occur. But ideally, this device should be turned off prior to surgery. And all of this is just to prevent inadvertent reprogramming or even activation during surgery from electromagnetic interference. The pulse generator location should be ascertained, as additional padding may be required to avoid pressure injury. Some of these patients are very skinny, and these generators are literally protruding through the skin. Also, if the device is placed within 6 weeks, even more care should be taken to positioning to minimize excessive flexion, extension, or rotational movements, which could increase the risk of dislodgement or lead migration if these leads have not fully healed and fibrosed to the skin. So neuroaxial techniques are relatively contraindicated because of the significant risk of direct damage to the leads and the possibility of introducing infection. However, if neuroaxial is highly recommended for these patients, spinal radiographs should be reviewed prior, and placement with an experienced anesthesiologist using fluoroscopy and or ultrasound is definitely recommended. Thoracic epidurals are considered to be contraindicated as well. And you see a radiographic image here of the pulse generator, and you can actually see the radio opaque electrodes in the patient's epidural space. Some more intra-op considerations. Avoidance of monopolar cautery is preferred, but they state that bipolar and harmonic is typically okay to use. Grounding pads, again, should be placed far and opposite to the stimulator. And as far as MRI is concerned, most of these stimulators are MRI conditional, as not all devices are approved for scanning, and the safety profile for the device is very device specific. So it's important to really talk to the manufacturer about which device this patient has. Postoperatively, the device should be switched back on and interrogated by the device representative to ensure the functionality before discharge from the hospital. It is also important to note that spinal cord stims have no role in the management of acute postoperative nociceptive pain, which should be managed by conventional means. In other words, these patients' pain regimen in the PACU should not be affected just because they have a spinal cord stimulator. Okay, so next let's discuss vagal nerve stimulators. So these devices are typically indicated for patients with refractory epilepsy. They are effective in many cases, but actually few patients achieve complete elimination of their seizures. Therefore, presence of seizures does not necessarily mean that the device is non-functional. This system consists of a programmable signal generator and similar appearance to a pacemaker, as you can see in this patient's radiograph, which can often be confused for a pacemaker if you were looking at the radiograph. The generator is implanted in a subcutaneous pocket in the patient's left upper chest, just inferior to the clavicle. And attached to the generator, you see some lead wires with an electrode that runs up and is wrapped around the left vagal nerve. So the way these work is intermittent electrical stimulation of the nerve serves to attenuate epileptic seizures. In regards to its use, each patient has a magnet that they carry with them. So following the onset of a seizure, the patient or the patient's companion can activate the device by placing the magnet over the generator for about 1 second, which causes electrical stimulation, and it serves to interrupt a seizure or reduce its severity. Placement of the magnet over the device for more than a minute inhibits the nerve stim while the magnet remains in place. And the vagal nerve stimulator will return back to its normal program setting once the device is removed. And the neat thing is the design for these magnets are often allow patients to easily carry it with them, often around the wrist, similar to a bracelet or a watch. You can see that in the image there. Identification of the device in the preoperative setting and consideration that the patient likely suffers from other chronic epilepsy features and maybe on anti-epileptic medications as well. And you need to keep in mind that certain agents may lower the seizure threshold, so all these other things may be considered. Typically, these stimulators do not need to be deactivated or inhibited via magnet placement during surgery. However, a discussion with the surgical team to minimize damage to the electrical circuitry from the electrocautery and positioning of grounding pads, very similar to other device recommendations, so as to prevent current flow through the device system and keep the current as far away from the device generator as possible. If going for MRI, these devices are also MRI conditional. Manufacturer instructions should be consulted, and post scanning device interrogation should occur as well. Now, some interesting points. Recall that the vagus nerve activates the vagus nerve also activates motor efferents and results in signal transmission to the laryngeal and pharyngeal musculature. Therefore, laryngeal dysfunction is possible in these patients presenting with perhaps voice discomfort, hoarseness, cough, pharyngitis, or even shortness of breath. Also of note, the left vagus nerve is preferred because the right vagus nerve has more cardiac efferents to the sinoatrial node, whereas the left vagus nerve mostly innervates the AV node, which has less influence over intrinsic heart rate, thus resulting in less bradyarrhythmias. So that's why the left vagus nerve is used. It is important to recognize acute laryngopharyngeal dysfunction, including vocal cord paresis, which may cause partial or complete airway obstruction in the non-intubated spontaneous patient, ventilated patient during anesthesia. The risk of aspiration may also be increased in these patients with dysfunction. So chronic vagal nerve stimulation may also depress postoperative respiratory efforts and increase the risk of obstructive airway episodes throughout the postoperative period. And although rare, like I mentioned about the AV node, dysrhythmias may occur, so these patients need a little closer monitoring. If defibrillation is needed or electrical cardioversion is needed, the manufacturer states that it may cause damage to the generator circuitry. However, it should not be withheld just because the patient has a vagal nerve stimulator. But if possible, the lowest amount of energy should be used, or the paddle should be placed as far away from the generator as possible. Postoperatively, if in the PACU there is significant cardiac or respiratory instability, not further explained by other causes, one may consider to disable the device immediately. However, there is a lack of evidence to show a benefit of prophylactically disabling the device completely during surgery. And of course, if it is disabled at any time, interrogation of the device is recommended. All right, so moving on to intrathecal pumps. Intrathecal drug pumps are a treatment option seen in patients with terminal cancer pain or chronic pain that has failed prior therapy. And these pumps tend to deliver small doses of medication directly into the spinal fluid. They consist of a small battery-powered pump that is implanted under the subcutaneous tissue of the abdomen and is connected to a small catheter tunnel to the site of spinal entry. They also contain a reservoir port, as seen by the arrow on the device, for refilling medications. So the placement of these devices consists of a trial phase prior to implantation. So they use an intrathecal infusion catheter, and infusion of the medication should provide a benefit of at least 50% pain reduction or just general improvement of function for successful placement. Typical medications used are morphine, hydromorphone, bupivacaine, baclofen, but there can also be others that are used as well. So for these patients, a discussion with the pain treating team, again, is important to have a clear idea of the device and the way that the patient uses it, the time of use, the last time the pump was checked, and which medication is in the pump and whether the dose is on demand is flexible. It is also important to determine whether the patient needs to reload the medication in the pump because the medication could potentially run out in the perioperative period. Familiarity of the symptoms and signs of overdose or withdrawal are very important. For instance, a patient already receiving intrathecal opioids at baseline, the addition of our typical procedure-related opioids may induce unwanted respiratory depression intraoperatively. And if the patient is receiving intrathecal baclofen at baseline, addition of opioids may have a greater than expected response due to the synergism nature of these drugs. Generally, these pumps remain active during the perioperative period, so there is no need to disable them or turn them off. A few things to consider. For these devices, temperature and positioning affects drug delivery. So at body temperatures above 39 degrees, which I know seems like a lot, but if you have a warmer position right by the device, it could potentially increase to above 39 degrees. The patient could be at risk of increased drug delivery and overdose. Also, when positioning, avoid excessive twisting or bending, as these can kink or occlude or damage the intrathecal catheter. So according to the manufacturer documentation, electrocautery is safe and is unlikely to interfere with the device function. So that's the benefit behind these devices. As far as neuroaxial anesthesia, it is not absolutely contraindicated in patients with these pumps. However, care should be taken to identify and avoid the entry point of the catheter into the spinal canal with prior review of imaging. And although this is challenging, I found a case series describing the successful placement of epidural catheters in patients with intrathecal baclofen pumps. For this study, 16 patients undergoing planned orthopedic surgery received epidurals placed under fluoroscopic guidance on the day of the procedure, and the pumps were interrogated prior to discharge with good outcomes. What about regional anesthesia? It is also recommended. A case report describing the successful use of lumbar plexus and sciatic nerve blocks as a primary anesthetic for a left total knee arthroplasty. In this patient was a particular patient with cerebral palsy and was using an intrathecal baclofen pump. The catheter was used even postoperatively for successful pain control, so it was a very good option. For OB anesthesia, several case reports also describe successful placement of lumbar epidurals in patients with intrathecal pumps, provided the catheters can be placed caudal to the pump insertion site. And of course, interestingly, ultrasound can be used as a tool to locate the pump tubing prior to insertion. For MRI, most pumps are conditional. However, prior to the scan, the device and model should be identified because differences do exist. For instance, Prometric Flowonics pumps should be emptied prior to MRI, and failure to do so can result in drug overdose. So it's something very important to consider. In contrast, Medtronic pumps do not recommend emptying the pump prior to the scan. It is also very important to note that MRI exposure temporarily halts the pump and suspends delivery of medications for the duration of the scan. Therefore, prior to any scan, it's important to determine if drug delivery can be safely suspended or if a drug needs to be supplied via an alternate route, such as an IV route. The device should be interrogated after completion of MRI and restarted appropriately. And keep in mind that special attention should be placed to patients receiving particularly intrathecal baclofen, as withdrawal can be life-threatening. Keep in mind that oral baclofen withdrawal can occur within days, but intrathecal withdrawal can occur within hours. All right, so let's switch gears now and discuss cardiac devices, which are a little bit more common and likely to see in the perioperative setting. So we're going to discuss pacemakers, ICDs, leadless pacemakers, also known as micro and implantable loop recorders. All these devices will be grouped together as cardiac implantable electronic devices, or CIEDs. So most modern pacemakers consist of a pulse generator, battery power source, and one or more electrodes referred to as leads, which deliver electrical impulse to the myocardium. These leads are typically placed either percutaneously or via venous cut down, which course through the venous system to the heart. The battery is implanted commonly in the infraclavicular region of the anterior chest. There are also leadless pacemakers, like I mentioned, such as the brand name Micra, which we will discuss later. And there are also epicardial pacemakers, which contains leads surgically attached directly to the epicardial surface of the heart. These are usually used for temporary pacing following cardiac surgery and then must be removed days following the surgery. We usually see these pacers during CV surgery, and we manage them in our patients in 2 ICU here at Loyola. Devices can be pacers only, or they may contain additional features to treat tachyarrhythmias by ways of defibrillation and antitachycardia pacing, such as an AICD, which is used in the primary or secondary prevention. In this picture here to the left, you see a dual chamber pacemaker in the RV and RA. You can note the lack of lead coiling in the leads, which would denote this device as a pacer only. For AICDs, this is the typical appearance in the defibrillation coils, which are radio-opaque, to denote this as an ICD. These are placed transvenously with the distal electrode position in the right ventricular apical endocardium. And dual chamber AICDs have an additional lead with another pair of pacing sensing electrodes in the right atrium. Most contemporary systems have 2 or 3 electrodes along with the distal coil in the RV. And ICD leads can have a second defibrillation coil proximal to the RV coil. And even so, some devices have what's called an active can technology, so what it's called, where the metal housing of the ICD itself serves as one of the shocking electrodes, which I thought was pretty neat. The pulse generator contains the sensing circuitry as well as the high voltage capacitors in the battery. And the small size of these generators makes them easily implanted under the skin or under the muscle. And just for completion's sake, we also recognize devices for resynchronization therapies, which are pacemaker ICDs containing a visible lead in the coronary sinus overlying the epicardial surface, allowing stimulation of the left ventricle. So in these images, in the bottom right image is a nice one. You can see a clear coronary sinus lead in addition to the right atrial lead and the right ventricular lead as well. So what about management of these devices? So first step is to identify which type of device the patient has, whether it be just a pacemaker, ICD, and how many chambers it involves. And this can be done using an H&P, medical records, and of course, just looking at a chest x-ray. Look for the presence of coils, how many leads, etc. Following identification of the device, it's important to involve the cardiologist and pacer clinic and surgeon as a multidisciplinary approach. Most devices should be ideally checked within the last 6 months if possible, and to determine the device burden and pacing. For a pacing device, now the most important part is that the next step is that recognition of the pacemaker dependence is very, very important. So how do we do that? Dependence is defined by a pacing burden of at least 40% or EKG tracings showing a predominantly paced rhythm. Finally, another step in management is to identify the surgical procedure and if it will contain EMI or electromagnetic interference. So that brings us to our topic. What is EMI? So electromagnetic interference is a potential interference or disruption of the operation of electronic device when it is in the vicinity of an electromagnetic field generated by an external source. So this matters to us because during surgical procedures, the function of cardiac devices may be affected by EMI, and it is most commonly seen when we use electrocauter unit. Monopolar being the biggess culprit, and then much more than bipolar, and then less of it a harmonic. There are also some less intuitive sources of EMI to consider, such as evoked potential monitors, nerve stimulators, even fasciculations, MRI, ECTs, large tidal volumes, which I thought was interesting, external defibrillation, ablation, and of course, shockwave lithotripsy. So in patients who are pacer dependent, EMI may be misinterpreted as intrinsic cardiac signals, resulting in oversensing and inhibiting of pacing, causing significant bradycardia, sinus arrest, or even ventricular standstill. In ICDs, EMI can cause noise, which provokes inappropriate defibrillatory shocks. So EMI may also potentially result in the failure of ICD therapy in detecting actual ventricular tachyarrhythmias as well. The first step in management is to consider a device check and reprogramming depending on the nature of the procedure. So the type of device is important to discover, and also whether you need to determine whether the patient has a pacing burden. So how specifically do you decide when to reprogram? So reprogramming is indicated in all patients with ICDs. So every patient that has an ICD gets reprogramming. Procedures where very high likely EMI will be present, and also in reprogramming in patients who are pacer dependent. Reprogramming may entail switching off the ICD anti-tachycardia therapies, such as the anti-tachycardia pacing and defibrillation, or converting the pacing mode to an asynchronous mode, such as VOO, and or deactivating the rate modulating features. Patients who do not fulfill the listed criteria generally do not require preoperative device reprogramming, and the device can proceed with a cardiac device magnet on standby. So magnets, let's actually talk a little bit about magnets. Magnet application, or the thought of, just put a magnet on it, is controversial, and I'll explain exactly why. So in pacemakers, magnets typically switch off rate modulation features and convert pacers to an asynchronous pacing mode, which prevents EMI-induced pacing inhibition. Asynchronous pacing will also continue until the magnet is removed, at which point the device will revert to its baseline settings. Note that Asynchronous pacing modes should not be used in patients that are non-pacing dependent, as pacing stimulus may trigger the R on T phenomenon, which I know we've heard many times, and could potentially result in a life-threatening arrhythmia. In ICDs, magnets typically switch off arrhythmia detection and anti-tachycardia therapies, but the magnet does not affect the pacing mode of ICDs. So this would require reprogramming. And also some devices such as Boston Scientific and St. Jude have the ability to be programmed to ignore magnet application, which underscores the issue behind the attitude of just put a magnet on it. Medtronic devices do not have such option, and for the most part, magnet application should reliably deactivate the device. Another interesting feature is Boston Scientific ICDs produce audible tones to let one know that the device has been successfully deactivated. So as one hears these tones, arrhythmia detection should be suspended, and the removal of the magnet reactivates the device, and the tones should cease. Also, it's useful because intraoperatively, if the device were to shift away from the proper positioning, the tones would also cease, indicating displacement of the magnet. So overall, each device is unique, and magnet placement should only occur after proper identification of device settings. Intraoperatively, cardiac monitors should always be placed to monitor changes in pacing behavior. Also, defibrillation and pacing pads should be placed on these patients' chests in an anterior-posterior configuration so that if malfunction should occur, you have a backup pacing or external defibrillation readily available. Again, if cautery is to be needed, bipolar harmonic is recommended, just similar to other devices. And they also state, and the reason I'm mentioning this is because I had a board's question about this, that they require short, intermittent, irregular bursts at minimal power settings using cut instead of coagulation. So all those little things can really assist with avoiding device disruption. And then similar to other devices, cautery dispersal pads should be placed in a position so that the current is directed away from the pulse generator. Postoperatively, after the operation, it's important to still closely monitor the patient with EKG, blood pressure monitoring, and defibrillation pads until reactivation has occurred. Reprogramming in the OR prior to transport is preferred, but if for whatever reason, if needed, and we've experienced this, if we're unable to get a hold of the pacer clinic, reprogramming in PACU can occur. However, you have to keep in mind that cardiac monitoring and the pads should remain in place until reactivation of the ICD if the patient has one. It's also important to reactivate any anti-tachycardia arrhythmia therapy. Sometimes this can be forgotten. So important to activate them after the procedure. And this literature review also stated that in a non-supine position, it's also important to note that the device may be unstable, and reprogram is also recommended for that as well. To summarize, a brief flow chart for management of pacemaker patients. In general, you start with information gathering, physical exam, communication with cardiac team, pacemaker clinic, but more importantly, you make the crucial decision from our end to determine pacing dependence of the patient, and the management kind of goes from there. So where the star is, you could either go down if they're pacer dependent or to the right if they're non-pacer dependent. All right, so let's discuss leadless pacemakers. This is a neat alternative to traditional pacemakers. The brand name is Micra. You may be familiar with these. These are placed at here in Loyola. The photo on the left shows a diagram of the device during placement, and on the right, we can see the device identified on chest X-ray. These leadless pacemakers are implanted endovascularly and directly in the myocardium of the RV. It's a great option for patients requiring only RV pacing, but it's also a limitation to the device. And given its intracardiac location and absence of a sensor, reprogramming cannot be achieved by clinicians at the bedside. So placement of a magnet prior to surgery does nothing for these patients, and it actually requires collaborative expert reprogramming. So preoperative management, the same with traditional pacemakers. Determine pacing dependence. If pacer dependent, discuss with surgical teams concerned for EMI, and if yes, convert the device to asynchronous pacing. If low concern for EMI, you can go ahead and proceed. Intraoperative monitoring and defibrillation pads, again, is recommended for these patients as well. And then typical interrogation and reprogramming following the procedure is also recommended. Now, as a final cardiac device, we will discuss implantable loop recorders. So these devices are indicated in patients with a history of syncopal or presyncopal episodes in attempts to record the arrhythmia culprit. These devices are usually implanted in the left parasternal position, and there are no leads or in or outside of the heart. So therefore, there's no need for reprogramming, and typically these devices do not present a perioperative risk. The primary concern is mainly a risk of directly damaging the device from surgical manipulation. Therefore, its specific location must be ascertained and possibly marked out in order to avoid surgical damage. And here's a radiographic image. You see where the device is. It's just conveniently placed right next to the heart there. There's no leads or wires coming from the device. It may be still important to interrogate the device before proposed surgery to determine whether the loop recorder has recorded a recent life-threatening arrhythmias, which may potentially delay or cancel a procedure, especially an elective procedure. So it's good to know that. And as far as MRI safety, the shell is made of titanium and the inside contains ferromagnetic components. So the device is safe to use in MRI, but the patient should be consulted that a pulling sensation may be perceived, which I thought was interesting. And just requires some patient education. And lastly, you should talk to your patients about letting their cardiologist know at their next follow-up appointment that they had recent surgery, because perceived arrhythmias detected on the device could in fact be interference from electrocautery during the procedure. So now, using the knowledge that we have discussed, let's attempt a real advanced board exam practice question, which I encountered on TrueLearn. So which of the following is not a recommendation for management of electromagnetic interference between electrocautery and implantable pacemakers, according to the American Society of Anesthesiologists Task Force on Perioperative Management of Patients with Implantable Electronic Devices? So which of the following is not a recommendation for management? Change pacemaker mode to asynchronous mode if a defibrillator is present. Place current pads such that the current pathway does not pass through or near the pulse generator and leads. Use monopolar electrocautery when possible. Use short intermittent bursts at the lowest possible energy levels. Does anybody know? I think I hear C up top there. So that is correct. So as we read before, monopolar electrocautery systems should be avoided if possible. But if used, B would be true and D would be true as well, and A is true. So for this answer, you can kind of eliminate to get to C. So to conclude, I think this topic is very important, as we're surely likely to see a rise in patients presenting to surgery with medical devices. We're going to be seeing more and more of these non-invasive device placements, and these patients are surely to present for other surgeries. So it's important to identify these patients, identify these devices, and have a good plan in place for management. And remember, regardless of the patient's knowledge or level of comfort with their device, patients depend on us for their safety. So the more confident we feel about those devices, the better hands those patients are in. A confident and thorough plan will reduce unwanted outcomes or reduce patient harm. So here are some references for my presentation, and I saved the best and most important slide for the end. So thank you. These are my kids. We have Vance on the left, who's 2.5, and then Sophia, who is 2 months. So thank you very much. Open up to any questions at this point.
While we wait for questions, sir. Excellent presentation, as expected. One thing that I know you would agree with is you should always, as part of what you referenced, you should always, at this institution, consult the EP lab before patients going for any procedure. And well, during banking hours, during off hours, you should consult the EP fellow on call. Because it's far too granular to get into now, but for one instance, a patient on a loop recorder, I was informed by the pacemaker clinic that they wanted to come up and download the information on the recorder so that they knew that they had it, because they were concerned about it being erased for due to the cautery during surgery. So some consideration that you don't know about they know about. So yes, as you said, you should always consult them.
Yeah, that's a good point.
Hey, elephant in the room, sir. What are your recommendations about insulin pumps?
Yeah, that's a good recommendation. So actually, I had insulin pumps in my presentation, but just for the sake of making things a little bit more concise. And insulin pumps technically were not categorized under the implantable devices section, although there is a cannula inserted, but most recommendations are actually to continue the patient's own infusion during the case. Some pumps also have a setting to slightly decrease the infusion setting, or they have what's called an exercise function in which it decreases the amount of insulin infusion. So if the pump has any of those options, you can continue it. If you expect a major trauma case or a very large stressful surgery that is very long, the other option is to discontinue the insulin pump and just to administer your own insulin infusion using intraoperative glucose checks and making adjustments as necessary, and continue that infusion until the patient's able to eat again and is awake enough to work their own pump.
Thank you.
Mhm.